Hello, you're listening to the latest season of the COVID Inquiry podcast. This week, Nicola is joined by Lorelei King, actor, screenwriter, narrator, and most pertinently, a member of the COVID-19 Bereaved Families for Justice group. Together, they're going to reflect on how the recent hearings went and look forward to the next few days of evidence. Please note, some listeners may find the contents of this podcast distressing.
Hello everyone, I am Nicola Brook and I'm the solicitor at BJC with day-to-day responsibility for managing our work on the COVID inquiry on behalf of the COVID Bereaved Families for Justice UK. I'm here with my co-host Lorelei King, who is a member of the group, having very sadly lost her husband to COVID. Joining us today to discuss the hearings this week is Enda McGarrity. He is the solicitor from PA Duffy, instructed by the Northern Ireland COVID Bereaved, and we work very closely together. Also joining is Dr Cathy Finnis, who gave evidence to the inquiry and came on our podcast in week 5. Dr Finnis was a medical doctor, but unfortunately had to leave face-to-face clinical work due to being severely immunosuppressed. And she is the deputy leader of the Clinically Vulnerable Families. Welcome both Dr. Finnis and Enda. Thank you for joining us.
So glad to see you both. It's been quite a week in many ways, not least of which was the testimony we heard. I wanted to touch, I know we have, I guess, more relevant to us witnesses to talk about, but I just wanted to touch briefly on the witnesses of day one, because I thought they represented so much. It's continuing theme this module, which is a lack of appreciation of healthcare workers, not listening to healthcare workers. And we have Patricia Temple, hers was impact evidence, who was a nurse, talked about how they were treated as disposable. And she said something that struck me. She said, you can't be clapped for 1 minute and then declared disposable the next. And I thought it just reminded me of that performative clapping, which provided photo ops, it seems, more than anything. And in the lip service that they paid to these workers, yet they didn't use their expertise, as Rosemary Gallagher, who was the professional lead for infection prevention and control. And she talked about how they failed to listen and how they warned about airborne transmission and were ignored. And then also we had Nick Hay from the pharmacies thing, who talked about how they were overlooked and unappreciated, which I have personal experience of. My pharmacist during the pandemic was tremendous help to me. And I just wondered if you guys had any thoughts about the witnesses on that first day before we move on.
Yeah, it was a very stark day. And as you say, the theme was overused and underappreciated. Both Patricia Temple and Rosemary Gallagher pointed out this, what appeared to them completely ridiculous instance of being told on a Friday, wear this mask today, tomorrow and Sunday, but on Monday you need to wear this other mask which will provide you with more protection. And I can understand logistics. Sometimes it may take a while to get things into place, but just the absolute insanity of saying to someone, we understand this mask won't provide the best protection, but continue wearing it for 3 days. And then on Monday, that's when you need to start wearing the higher protective mask. That just seems absolutely insane. And no wonder anyone working on the front line thought, no one cares whether I live through this. They just want me to keep turning up to work.
And what did you think about it?
Yeah, totally agree. I think overall, Patricia Temple's evidence was a very candid and realistic portrayal of the difficulties on the ground experienced by staff and those working on the front line. There was helpful insight. It was a very helpful insight because much of the rest of the week was evidence from those in managerial or corporate positions who were developing guidance or disseminating it. So it was really that stark contrast between what the evidence heard on Monday and what followed. I think the quote that Patricia Temple finished her evidence with was, nurses should not be viewed as disposable, and every attempt should be made to retain this valuable resource. And as you mentioned, Lorelei, that will ring true with a lot of nurses throughout the four nations. Similarly with Rosemary Gallagher, what I found most interesting was the layers of bureaucracy that are in place in a scenario where, for example, a staff nurse notices infection control issues and wants to escalate those. They have to report first to a manager, then to a senior manager, then through various other levels of governance. And who knows whether it actually gets to the people who are developing the guidance. We'll come to speak about Aidan Dawson and the Public Health Agency in Northern Ireland, but for those with responsibility developing guidance, they said that they had heard no concerns around PPE from staff on the ground. We know that's nonsense, but notwithstanding that, there would be a really legitimate recommendation to be made around removing or streamlining those levels of bureaucracy so that the voices of staff can be heard.
It's a really good point. And Dr. Finnis, Cathy, if I can come to you, did you catch some of the testimony on the first?
Yeah, I did. So I do still work in the NHS. So I was working, but I did catch a little bit and catch up. I mean, I agree with everything that's been said. I think, I think that's exactly right. And I think, we've got, I mean, if I can, we've got a big morale problem and a big burnout problem now in the NHS, particularly amongst staff. And we know that there are many, many vacancies, particularly nursing vacancies nationally. I mean, is there any surprise really, given how they feel treated as a profession? So yeah, I think the knock-on effect of that, and all that's kind of come out through the inquiry about, their lack of, we knew some of it obviously at the time, but what we've learned since kind of really helps to colour how people must still be feeling.
And you mentioned Aidan Dawson, who's the chief executive of the Public Health Agency Northern Ireland. And I'm sure you want to talk about his testimony. So have at it.
Yeah, look, it was quite remarkable. There's been a lot of discussion since with our client group, who are appalled, to be frank, and also within the hearing room at the time. I think there was a bit of disbelief, not only for the level of inaction during the pandemic, but probably more so the lack of reflection since, and the lack of discussion that has been had with his team. He is the chief executive of the Public Health Agency, who had major responsibility during the pandemic. He answered many questions with, I wasn't there at the time, or I haven't discussed this with my team. And, frankly, for our clients, that is nowhere near good enough. And, I'll go through some of the examples of the failures that were set out during his evidence. There was inadequate data gathering. Data was a huge thing, across the week, by the way, and we'll maybe come to that when it comes to the likes of Jenny Harries. But there's a black hole in relation to data with Northern Ireland, and there's a real lack of adequate data. One of the points Aidan Dawson mentioned was that an issue with that data shortage was the fact that they couldn't get data from GPs and from the community generally. It was a bit easier to get it from the hospitals. So he said that at the time there was then media coverage which followed, with someone from the BMA saying, no, absolutely, GPs were offering the data up. So, who knows? We really should have someone giving evidence from the BMA in respect of Northern Ireland to really get to the bottom of those issues. Other examples were failure to develop adequate IPC, infection control.
I'm sorry, Enda, I'm so sorry to interrupt you. I just had a question there. You mentioned about the BMA, because I know that Lady Hallett referred to, or somebody said, wasn't Dr. Stout from the BMA, was that in previous module, had denied what he was saying?
Yeah.
What Dawson was saying?
But actually, I think that's who came out and gave the quote in the media afterwards. So, it's an issue of concern. I don't think it will be lost on the inquiry that there are factual issues with that. and that data generally in Northern Ireland is way below the level that it should be, and that has a knock-on effect to every aspect of pandemic response in terms of how do you develop guidance, how do you deliver the guidance, and how do you monitor it? How do you see how it's actually how it's being implemented? So pretty serious concern, and as I said, even more concerning that it hasn't been not even rectified, but even discussed since. So look, the clients, having spoken to them afterwards, are very frustrated with that. One of the big difficulties is that we have 75 minutes where Aidan Dawson's able to give evidence at the inquiry. It's nowhere near enough to really delve into it, although it was quite shocking that with some pretty basic questions put to him, we were able to extract that level of failure. So the question would be, if there was proper time allocated and proper scrutiny of him and others, what further would be uncovered. But look, it was important, as you know, there's not many Northern Ireland specific witnesses in this module, so it was important that he did give evidence, and that those issues were laid bare, and it's something that we've been aware of for a while, and I think it's in the wider public at this stage now.
I'm sorry I interrupted you, and do you want to carry on with what you were saying about this witness?
Yeah, so a couple of other important issues. I could speak all day about about this evidence, but one of the other issues was really around end of life visitation and getting that balance of the risk of harms between giving someone the dignity of an end of life visit, and balancing that against the risk of infection prevention and control. And it's very clear that the PHA in Northern Ireland didn't balance that risk properly. And again, in keeping with the theme of Aidan Dawson's evidence, haven't reflected on it since vitally. And that's really quite concerning for our clients, because one of the lasting legacies from the pandemic for them is that inability to gain closure. Death rituals are extremely important in Northern Ireland in terms of wakes and funerals. They're done a little bit differently, perhaps, from the rest of the UK. And not only did many of our clients not have that, they're pretty concerned that there hasn't been reflection on the fact that those were denied, and how that balance might be struck better in future. So yeah, pretty concerning overall.
I agree, Enda, with that. I just know it for the bereaved, this is a gaping wound, the end of life thing. Nicola, what are your thoughts?
Thanks. Yeah, this was actually a master stroke of questioning from Brenda Campbell-Casey on behalf of the Northern Ireland COVID bereaved. She pointed out the timelines that over in England, we had changed the guidance to permit visiting in January, but in Northern Ireland that didn't happen until I think it was September. And so whilst over here we could have visits at end of life, there was a 9-month delay in that happening in Northern Ireland. And Dawson did concede that that should give rise to concerns that there wasn't the urgency. But when he was asked why there wasn't the urgency, he just said, "Oh, I don't know. I've not asked my team." And it was just startling that he hadn't thought to question his team about that and really drill into it. But even more than that, if you're going to visit restrictions as a way of controlling infection, you have to at least check that it's doing its job and working. And when counsel to the inquiry was questioning him, he admitted that there was no tracking of whether IPC guidance was being followed. There was just an assumption that it was being adhered to. And there was no tracking of whether the IPC guidance was effective. And so Nick Scott, on behalf of the inquiry, put to him, "You're in charge of setting the guidance. Should you not also be checking whether it's being applied and whether it's working. And if you're not doing that, is that not a failure? And Dawson simply answered, yes, accepted it was a failure, but there was no reflection of, yes, that's terrible. This is why it didn't happen, or it was just a complete lack of embarrassment at how badly they had performed. It was absolutely striking.
I think and as I said, these things, to see witnesses like that who just seem to be untouched by it. For those of us who every day are touched by what has happened, it's hard to watch. I think another witness, I know for a lot of the brief talking to them, that was hard to watch was the return of Professor Dame Jenny Harries. I wonder if we could move on to her testimony now, and I'd like to come to Dr. Finnis, to Cathy for this. I'm sure you had some thoughts.
Thanks, Lorelei. Yes, we surely did. There's been a lot of discussion within clinically vulnerable families, certainly about the evidence that she gave, and I guess a lot of emotions too that have arisen from her testimony. And I'll try and, if I can, present some of those, if that's all right. I suppose, firstly, this whole kind of airborne thing, and I know that that's been a strong theme throughout this module, but I think we were all, myself included, I was actually in the inquiry room for Jenny Harries' evidence, and I think when she said, oh, well, it's always been airborne kind of thing, and that certainly wasn't, I guess a lot of our recollections in clinically vulnerable families, and apparently her recollections weren't the same. I don't think that that certainly we had no understanding that it was airborne, and those of us that, for example, were shielded or higher risk, we were never given any information about that. And obviously, I don't know if anybody else remembers this, but we were certainly told, I'm pretty sure it was Chris Whitty, that masks don't work early on in the pandemic. And it's all part of that. And it's as if, you can't rewrite that. But obviously, when that kind of thing goes down into testimony, it feels like it is. And people were still arguing that it wasn't airborne at that point. And obviously the really important thing within particularly hospitals, nosocomial infections, which has been another discussion during this week, is that IPC didn't then reflect the fact it was airborne. It was very much based, wasn't it, on droplet and fomite transmission. The second thing that where we don't seem to have the same recollection is around shielding. And for those of us, including myself and 2.1 million people early on, which rose to 3.9 million people, it did not seem voluntary, particularly in those early weeks and months. And many people were affected in terms of their jobs, financially leaving their job if they weren't supported to work from home. SSP actually came in April. There was a gap there. And so some people sadly did lose their job, either because they were didn't realize they could gain that and they just resigned from their role, or for other people, such as actually happened to my husband, was actually made redundant due to his shielding in the summer of that year. And so there was really significant effects. And certainly if we'd have known it was voluntary, would we have taken that action? It just felt like it wasn't our experience, and many people. And the other thing to say about that is, even if you were told it was voluntary, the communications that we were receiving by text, email, and letter was so severe that you were at very high risk of death should you step outside your house. I mean, literally early on, we were told not to go into our gardens. We were told, it did feel we were told simply to open a window. We were told to put a bag by the front door. The level of fear in that population was very traumatizing, and obviously remains, particularly for people for whom this hasn't gone away. And I suppose that leads me on to the next point, which is the question about there's two questions, I suppose. I think that the counsel to the inquiry mentioned my evidence about immunosuppressed people in particular, but involves all clinically vulnerable people at high risk of COVID accessing hospitals today. I mean, that question just wasn't answered, and I think that the evidence that was given in response to that question was that, well, when we sent the shielding letters out, there was an additional paragraph for people who were clinically extremely vulnerable to contact their GP. I mean, maybe in the first 4 weeks that was acceptable, but in 2024, none of the IPC guidance has still not moved to reflect the fact that this virus is airborne and the fact that there remain people in 2024 who are at higher risk. And there's just a complete dismissal of that, I suppose. And that was borne out in her question about the public information campaign as well. Our counsel, Adam Wagner, asked her, would it be of benefit, given the evidence that I gave on mask abuse, to give a public information campaign about people who remain at higher risk, who still need to wear masks? I think her response was, possibly, maybe, something about higher risk, but certainly not about masks. And by the way, COVID is the same as flu and RSV. And I just want to challenge that, really. Actually, this is airborne. We've just agreed it's airborne. Masks is probably the only real way. I know there's all this about hierarchy of controls, but given that the hospital estate is not safe in terms of ventilation and clean air, that does mean we have to use PPE. It's just a complete kind of dismissal of our kind of requirements and needs. And this whole thing about COVID being the same as flu, it's just not borne out. It's not seasonal. It's still, unfortunately, not many, but there are still too many people dying of COVID, hundreds a week during waves. And of course, the clinically vulnerable, many of them are still behaving in a kind of restricted way, in limited life way. So the death rates actually may be higher if we were all to suddenly come out and stop wearing masks. We also are eligible for antivirals if we can get them in a way that we're not for flu. And we also have those of us that are immune suppressed, twice yearly boosters in a way we don't for flu. So clearly it's not the same. And of course, we all know about long COVID. And I don't know what they would say about that either, but I imagine that they would also not agree that COVID is not the same as flu. And so that's really just some of the issues that I had, Lorelei, or we had as a group.
Yeah, I'm going down to the memorial wall today to update the number of COVID dead, people who've died this week. So everything you say is absolutely true. I mean, for me, there was a lot of, it was treated almost casually and a lot of rewriting. And Lady Hallett, to her credit, did press her a little bit, saying, didn't we know that SARS was airborne and all that? But she said these extraordinary things like, well, most people recognize it as a spectrum of transmission. Most people do not recognize that. Most of it, I have no idea even what that means. And I just found it, yeah. Enda.
Yeah, I very much agree with your last point, Lorelei, about the general public not having an understanding, despite what Miss Harries thinks. Her evidence reminded me a lot of Chris Whitty, both very much in control, both had similar narratives, both clearly very intelligent and occupy that slightly unusual role which straddles policy and science. And obviously both were on the podium and had a responsibility during the pandemic for speaking to and communicating these complex issues to the public. So I appreciate that these issues are nuanced, and the answer is always not quite that simple. But I do believe that some of the information is quite defensive, or some of her evidence is quite defensive. There's not a huge amount of acceptance of what might have went wrong, what could have been done better. And ultimately, as you say, the language is not democratized. There isn't really a broad understanding of what she's talking about for anyone who isn't really finely tuned into the work of this inquiry.
I just remembered one thing, and Nicola, I wonder, did I hear this wrong? At one point, it seems she was talking about the FFP3 masks, and she said there was no shortage of masks. The problem was that people weren't asking for them. Did I mishear that? Did I misunderstand that?
It's difficult to describe her evidence. one word is frustrating. She was asked about the BAME community in particular and concerns amongst healthcare workers from the BAME community about adequate protection. And essentially said, well, that's just because people from that community didn't feel comfortable having the conversation. But once they had the conversation, it was all fine. Essentially putting the blame on them for not coming forward and having the conversation, which was frustrating. But actually something that was outside of her evidence, she was due to give evidence on Wednesday afternoon and continue on to Thursday morning. Now, we weren't given advance notice of this, but right at the start, the chair said, we will finish your evidence today because there was a funeral that she wanted to go to the day after. And I thought, well, at least you're able to attend that funeral, because there are so many people in our group who either weren't able to attend a funeral at all or were not able to attend a funeral that was done in the way that it should have been and would have been carried out in any other time. And I thought, what a luxury you have to be able to pay your respects in the appropriate way. And the inquiry is moving things to ensure that that can happen. And that struck me, and I know it will have struck many of our members.
It did. I gasped when she said that, and I thought, nice for some. The callousness of even mentioning it, it didn't go unnoticed. Enda, I can tell you're thinking something. What is?
Yeah, I'm thinking here about one of the last things that was said in Jenny Harry's evidence about the key recommendation for the future, and she immediately answered data. And to be fair, to her credit, there had been a huge emphasis on data throughout her evidence. It's maybe some of the more bland or boring stuff, but it really does matter, and I think that's something that's very much been accepted throughout the course of the inquiry. And there's been quite a bit of work going on in the UK to improve systems for gathering data. I'm sure it's not perfect, but one thing's for certain, it's streets and streets ahead of what Northern Ireland are doing. And it's in contrast to Aidan Dawson's evidence around the lack of capability to gather data in Northern Ireland. So I thought it was an interesting contrast of where Northern Ireland lay in comparison.
Thanks, Enda. Well, after Harry's, we had testimony from Professor Sir Stephen Powis, the National Medical Director of NHS England. And this is just purely subjective, but this is my hackles went up with this witness, who I found to be kind of controlling and trying to control the narrative. I'm going to come to Nicola first for your thoughts about him.
Hi, yeah. So he is the clinical director for NHS. And I think what's striking for me is one of the first things he said, which was that the NHS doesn't provide services. And there's this whole complex layer for how the NHS operates, and that it commissions and it doesn't actually do it itself. So that, for me, was an interesting thing to say at the start of his evidence. And I thought, okay, so he's setting his stall out quite early that whatever happened, it wasn't his fault. So yeah, that was something that was noticeable, first of all. And then he started out talking about baseline beds, and that we were operating on the 23rd of January at 2021, 51% above baseline. But that still wasn't enough for him to be able to say that we were running out, or that it was critical, or that we'd reached CritCon 4. And it was just, NHS was under pressure. but they were coping, is what he was saying. And I think if you look at the evidence of Professor Fung, there are very different ideas about what coping looks like. And I just don't think this word coping is adequate to accurately reflect what was going on. And I think it's used deliberately to avoid the truth, which is that actually the NHS wasn't coping, and this whole evidence about the escalation of care and the critical decision-making tool, undoubtedly there were ceilings of care that were placed on patients because the NHS did not have sufficient beds. And anyone who has any doubt about that, again, just listen to the testimony of Professor Fong. Look at the surveys that have gone out where you've got vast percentages of healthcare workers saying they felt unable to provide care. And that's why having these very, very powerful directors giving evidence in one sense is almost meaningless, because without the evidence of the people on the front line, it just bears no resemblance to the actuality.
I think that's a really good point, Nicola. And I think again and again in this podcast, among other places, we just talked about how the NHS wasn't overwhelmed because, in our opinion, many of us, because care was rationed, supplies were rationed, all these decisions were made so that it would appear it wasn't overwhelmed. He also talked about the clinical frailty scale. I wonder, Dr. Finnis, Cathy, if I could come to you about this.
Yeah, so it's interesting, isn't it? So certainly within clinically vulnerable families evidence, my statement, we talk about this. We talk about, and they are linked in my mind anyway, the DNA CPR orders and the COVID-19 decision support tool. The COVID-19 decision support tool, was never, I mean, we were told, was never used. But certainly my concern, even at the time, was that it was released into the public. Many people, myself included, could tot up our scores and realise quite how unsavable we were. And I suppose that was the only other thing I was going to reflect on, what you were saying about this kind of rationalisation of care and whether everybody was able to access the care they need. I mean, I think we've heard enough evidence either from the bereaved, group within the inquiry or in other sources that there's certainly groups of people who weren't even taken to hospital. People within the care home sector, the learning disabled community that were affected so incredibly badly. And I thought what was particularly interesting for me about the DNA CPRs was that there was clearly an order that I hadn't appreciated and didn't know about for people with learning disability to check, quite rightly, that they didn't have any sniff of blanket DNA CPRs. That means by virtue only of their learning disability. But we in clinically vulnerable families would say that that didn't go far enough, and actually there needs to be a review of DNA CPR orders that were put on place really since March 2020 to today, for people particularly on the shielding list and people who are perhaps clinically vulnerable, or actually perhaps they just all need to be reviewed. All of the orders that were slapped on since 2020, we need to review them. Because we've heard evidence, haven't we, that there were blanket decisions made in hospitals. How was that done? Was that done through DNA CPR orders? Where else did that happen? We've got evidence within our group that people were cold called on the basis of simply being on the shielded patient list, who wouldn't have been expected to. They weren't critically ill. They weren't terminally ill. They would have been expected to maybe live a normal life expectancy, yet they were only in their early 50s. And they were completely cold called in a way they wouldn't have been just before the pandemic. Do you want to be resuscitated? Because we believe that you wouldn't be able to be. And I believe that that was all part of this kind of rationalization. So it was a pre kind of step, wasn't it? So that people who had DNA CPRs, what did that actually mean? Did that mean that they might even not be admitted to hospital at that point? That they would be treated at home, for example, or treated within a care home, for example. The COVID-19 decision support tool is and was a concerning thing because it did use clinical vulnerability or comorbidities in a kind of very perfunctory way with a score attached, as was age, as was this kind of frailty scoring. I guess my concerns about this are several, but who agrees this? Who manages this? What groups are agreed? When does this start happening? If it's developed in peacetime, I think people keep using this. We would say it's not. We're still in a pandemic, but if it's developed, then at what point do you suddenly start using it? Do you use it all the time? At what point? The NHS is frequently under pressure, as Nicola said. I mean, isn't it? Every winter we hear about corridor care and about really the rationalisation of care. At what point does that tool become really accepted? And then that kind of who do we not save becomes not even outside of the pandemic. I think there would be a lot of concern within patient groups that this tool be developed, to be honest, because we understand that it kind of takes the pressure off in a way, those acute decisions, but we would still worry because really those decisions should be taken at the point of care in that context with the person who's in front of you and not decided by a perfunctory tool.
Yeah, I agree, Cathy. And I know this is like a hot topic. And the fact that they make statements. He said, we issued a statement that blanket DNA CPRs were unacceptable, but I don't know, talk is cheap. That's what I say. And what did you think about this issue of frailty and scale?
I think sometimes we can get drawn into quibbling around the terminology. Nicola has mentioned the different perspectives on hospitals being overwhelmed. The same with blanket DNRs. What is the metric for referring to it as a blanket DNA CPR issue? Clearly, there was enough concern across the UK. Certainly it's something that we've been aware of in Northern Ireland for a few years, but it's clearly a UK-wide issue, and clearly there has been sufficient concerns raised for Stephen Powis to issue warnings about it quite early in the pandemic. So, whether or not they consider it to be a blanket DNA CPR, I think it's clear that at least in places throughout the UK that policy was in place. Related to that, I often think about those who can't advocate for themselves when these discussions are had, those with dementia, learning disabilities or communication difficulties, for example. And Stephen Powis discussed the issue of what we would call care partners in Northern Ireland. I think the terminology is slightly different in the rest of the UK. But the idea of having a family member built in to the care of their loved one, and this is relevant to DNA CPR because, if someone isn't there, I can't remember who gave the evidence this week, but somebody said that often the discussion around DNA CPR is had because a family member accompanies someone when they're admitted to hospital. So there's a natural time to have that conversation. And clearly there wasn't adjustments or enough adjustments made to have that conversation in another forum. So I suppose one of the positive things in that respect was that Stephen Powis recognised the importance of having that care partner, whether it's in a dementia scenario or a birthing partner, for example. And it's relevant to two of our witnesses for this module. When I think of Catherine Todd, who gave evidence at the start of the module around maternity care and her partner TJ being denied access. And that was in July 2021. The guidance, at least in England, around maternity care access was in December 2020. So another huge gap from when it's recognised in England that access should be permitted and when it isn't implemented in Northern Ireland. some months later. And then as well as that, Martina Ferguson has been a huge advocate of care partners in care homes and in hospitals, and will hopefully speak about that when she gives evidence as well. So it was helpful to have an acceptance of that, I think, during Stephen Paris's evidence.
It's a really important issue to many of us. To me, my husband died in care, and I was separated from him. So this is something really, really important for the future. I'm going to come to Nicola in a minute, but one thing he said really struck me. It was a kind of slip. He said, I think he was asked about if he had consulted with disabled groups, and he said because of the speed of the situation, we didn't have the luxury of consulting with disabled groups. Now he kind of course corrected quickly, but I think that says something, and this is come out throughout this inquiry as well. I think it says something about our attitude in general as a society, that having to consult with the disabled is a luxury. You mentioned people with dementia, there are people with learning disabilities, and I'm thinking of that, and that really struck me in his testimony. Nicola, can I come to you about this witness?
Yeah, so the failure to consult with disability charities and organisations, the opportunity to be consulted would not be considered by those organisations as a luxury. And it should have been considered by the NHS as a responsibility and a duty. And the failure to do so, in my view, has led to deaths. Just look at John Sullivan, who gave evidence about the death of his lovely daughter, Susan, who was denied access to the intensive care unit because she had Down syndrome. That's not me saying that. That was written on her medical notes. And the evidence he gave was that they heard about blanket DNA CPRs around March and April. So they took immediate action, wrote a letter that went out to everyone on the 3rd of April, saying that learning disabilities and Down syndrome should never be a reason for issuing DNA CPR. And furthermore, it shouldn't be used as a reason for the death on the death certificate. Now, that I would have thought was pretty standard information and shouldn't have required such a reminder. But it's even more concerning when you know that this problem was known about even before the pandemic. So in 2019, there was a learning disability mortality review, reviewing DNA CPR notices that were put on people in 2018. And they found that learning disabilities was frequently cited as the reason for the DNA CPR notice. Not because a clinical decision had been made that DNA CPR wouldn't work, but because they had a learning disability. Learning disabilities are not fatal. So why that would be marked as the reason is beyond me. But once they know about this in 2019, NHS England, again, writes to everyone saying that that's not appropriate. So if that was happening in 2019, when we were in business as usual mode, why on earth wouldn't it be happening during the pandemic when everything is stretched? And if they had to write a letter about it in normal times, why did they think a letter during the pandemic would be sufficient? Surely that must have sounded the alarm that our hospitals are not coping and that decisions are being made to ration care despite what we are telling them. They are clearly struggling and need more support. That's what stood out to me.
Yeah, that has come out in other testimony as well. I agree. It's horrific, some of the things we're hearing. On Tuesday, besides Aidan Dawson, we had Laura Imrie, who's the clinical lead for NHS Scotland and antimicrobial resistance and healthcare associated infection, ARHI. I was preoccupied Tuesday. I did not hear her testimony. I wonder if anyone would like to talk about that. Enda, did you have thoughts about her testimony?
Yeah, my initial perception of RHI was that it was a very innovative group that was set up and set Scotland apart from the other devolved nations, at least, because they had their own bespoke group, which looked at IPC guidance, which the likes of Northern Ireland didn't have. But after hearing Laura Emery's evidence, I'm not so sure that I'm right. I think she was dogmatic, at times contradictory, and very, very defensive, sticking to a clear narrative. Much of her evidence in respect of airborne transmission was at odds with some of the widely accepted evidence that we've heard in Module 3 to date. The chair will decide, what side of that argument she falls on. But I think few were convinced by the narrative that Miss Emery tried to put forward.
Nicola, what did you think of?
So, like Enda, I had the perception from evidence we'd heard earlier on that RHI had done a good job during the pandemic in helping the Scottish government figure out where to go and what to do. But having heard her evidence, she was deeply unimpressive. Was tying herself up in knots, contradicting herself. And it's all about IPC controls and the precautionary principle as she sees it. On the one hand, she agrees that the precautionary approach should apply, but then when you drill into the actual measures, she throws that out the window. So despite the fact that the Health and Safety Executive don't classify surgical face masks as PPE, we know the IPC cell, in fact, recommended those masks. And it's all about there being insufficient evidence to establish at that time that COVID was airborne, despite the fact that it was classified as a high consequence infectious airborne disease. But that's not the precautionary principle. It's not, do we have enough evidence to say that it is happening? It's, is there a risk that it's happening? And what do we need to do to guard against that risk until we have more evidence to prove one way or the other? And I think, although her evidence was deeply frustrating, I think we actually got a glimmer of truth from her, because in response to counsel to the inquiry, she said, you're talking about applying a precautionary principle in relation to PPE. And then she said, but there's also the supply issue. If we wrote guidance as a precautionary principle to put everybody into FFP3, she said, not only would we have a large workforce that couldn't comply with the guidance and therefore wouldn't come into work where we had high-risk areas, we wouldn't have enough masks for the intensive care units. So that for me was the one bit of truth, that if you recommend FFP3s, you don't have enough to give them to your workers, so they're not going to come into work. It was actually, we got to the truth, although I don't think she meant to say it, because she then said supply was not driving the advice, although she would concede that it was a consideration. But she said, if we said to staff, we think you should have an FFP3 mask, but actually we don't have one to give you, that would have caused unbearable anxiety. And that's probably true. But by saying, no, you don't need an FFP3, this FRSM will do the job just fine, workers not only didn't feel safe, they felt they were being lied to. It's one thing to say, we think an FFP3 is what's going to provide you with the highest rate of protection. We don't have enough to give one to you. We're seeing what else we can do. We're urgently looking to get more in. In the meantime, take all the precautions you can. If you don't feel safe, come and have a chat. We'll see what we can do. And it was striking, the evidence from her. But what if you contrast her evidence with that from the witness who was from the Spotlight Hospital in Birmingham? Now, they said that for anyone in their team, they were able to source 1,000 hooded respirator masks. And so for people who couldn't be fit tested or were fit tested but couldn't find a mask capable of fitting, they were given a hooded mask. Now, why was his hospital able to do that and others weren't? And I don't know who the right person is to ask that question, because we know that there was this central procurement supply, but there was also individual supply issues. And I don't know whether Stephen Powis is going to be asked about that or whether he will simply say, not my remit. But I do think Laura Imrie got us closer to the truth, albeit I don't think she intended to say it.
Thanks, Nicola. I'd like to ask you, each of you had as I always like to ask, if you had a standout moment or witness. I'll start with a moment of mine that I just thought was interesting. It was Professor Fu Manco who said, he said, when he was asked about lessons learned, he said, I don't know if lessons were learned, but lessons were identified. Now, this quote kind of resonated with me because it's a worry of mine. Throughout this inquiry, I feel like we're identifying so many things that need to be done differently. But are they? Is anything changing in spite of the devastating evidence we're hearing? That was one of my standout moments. Cathy, Dr. Finnis, can I come to you for yours?
Yes, thank you, Lorelei. If I could just link the two witnesses, particularly for CVF this week, which was Harries and Powis. I think, the moment for me was where Harris said it was airborne. Thank goodness she agreed, because obviously that's not the case, is it, for all experts we've heard from? But despite that, we still didn't really get any traction on the need for current airborne IPC measures. So we're back to that, our FRSM is adequate again. Nicola, they're still saying that even today, even all those years on. And I guess to reflect as well on Powis, and when that evidence came that IPC had been downgraded by Omicron, and it wasn't upgraded, and so they accepted the nosocomial risk of, I think it was 35% was what was said in evidence, and we're still there now. And I think for me that was the moment where none of this makes sense.
Thank you for that. And as always, I just wanted to say, sidebar, always appreciate so much your perspective on Northern Ireland. It means a lot to the people who listen. I know that. Did you have a particular moment or witness?
Yeah, thanks, Lorelei. Yeah, a bit of a low light, I suppose, in respect of Aidan Dawson's evidence. I've mentioned the lack of reflection, and Brenda Campbell's questioning of him really brought that out quite well. Something that's important to note is that a lot of the bereaved families have met people like Aidan Dawson, including Aidan Dawson and the Minister for Health, who we'll hear from soon. They're hearing these platitudes about we're ready to learn lessons for the future, we're ready to address and identify the issues. And then the reality is very different when you hear from the likes of Dawson this week saying that discussions haven't been had about some of the major issues. So quite depressing for the families and just for people from Northern Ireland generally.
Thank you. And last but not least, my co-host Nicola, what was your main moment?
I'm going to push my luck and pick two, and it's two lowlights instead of highlights, I'm afraid. So Nick Kay from the National Pharmacy Association, his evidence about how pharmacists, obviously everyone was being sent to their pharmacist rather than going to the GP in the first instance, so they were completely overwhelmed. And yet when it came to PPE and vaccinations and testing, they were the back of the queue. And that's because they were either considered as retail or as private sector healthcare. And it really just, they were completely unappreciated, and that should not happen again. The other one is Professor Simon Ball, as I mentioned, from the Spotlight Hospital. His evidence was good, and it seemed that what they did at his hospital was dynamic. It was looking ahead of time at what they should be doing, so that when the pandemic hit, they were better able to respond. I think it's just this term spotlight and what we thought that would mean, which was to shine a spotlight on the hospital and look at it in detail. So we've had the evidence from the head. What we haven't heard is from the people on the floor about the reality and whether what he set out was felt by them. Do the doctors agree? Do the porters agree? Do the cleaners agree? Do the patients agree? Do the visitors agree? And that is what's missing from this idea of spotlight hospitals.
I agree. There's so much testimony we should be hearing that sure we won't, the kind of witnesses we need to hear from. And I agree with you about Simon Ball. I was a little bit jealous. I mean, I love the family care network that he described. I would just, as always, I have to thank you all on behalf of the COVID Bereaved. They're just so grateful that you take the time to talk to us about the inquiry. And so thank you very much, Dr. Finnis, and as always, Enda.
Thank you, Laura.
Everyone.
Thank you.
See you soon.
Thanks for listening to this instalment of the COVID Inquiry podcast. We hope you found it insightful and interesting. If you did, please rate us on the podcast platform you use and share the pod with friends and family who may value this type of commentary. We're looking forward to you joining us next week for more expert commentary, opinion, and insight into the COVID Inquiry evidential hearings.